Intravitreal injection. This is Professor Maha Shahin, Mansoura University. With the increasing use of intravitreal injection, it's important to have a clear understanding of the procedure. Intravitreal injection is intended to overcome the blood-retinal barrier to deliver the drug at a therapeutic level with minimal systemic complications. It's one of the most commonly performed ophthalmic procedures worldwide. Intravitreal injection was used to deliver antibiotics for treatment of endophthalmitis since 1944. Now, many drugs are used for intravitreal injection. Anti-VEGF, anti-vascular endothelial growth factor, which include Lucentis, Avastin, and Eylea. Steroids, namely triamcinolone acetinoid, steroid implant, for example, Ozurdex, multiple antimicrobial drugs, antibiotic, antiviral, antifungal, air and other expansile gases, and chemotherapeutic agents. We are going to discuss the most commonly used drugs for intravitreal injection in retina practice. On the top of them is the anti-VEGFs. The available anti-VEGFs are Lucentis, ranibizumab, Avastin, bevacizumab, and Eylea, aflibercept. First, Lucentis was approved for treatment of diabetic macular edema and excessive form of age-related macular degeneration. The indications in age-related macular degeneration is treatment of neovascular membrane, of active neovascular membrane in particular. The dose of Lucentis is 0.5 milligram, which is different from the FDA-approved dose for the diabetic macular edema. The dose of Avastin is 1.25 milligram. And the dose of Eylea is 2 milligram every 2 months. Following the loading dose. Following the loading dose, the protocol may be injection monthly or PRN injection. PRN means as needed, or treat and extend. And by treat and extend, we mean that extending the period between each injection by 2 or 4 weeks. Another very important indication of use of intravitreal anti-VEGF is its use in treating diabetic macular edema. What are the indications of anti-VEGF in diabetic macular edema? They are used to treat centrally involving diabetic macular edema. And the indication also include certain conditions in cases of proliferative diabetic retinopathy. Screen diabetic patient for diabetic retinopathy. If there is no retinopathy or mild retinopathy but sparing the macula, then just controlling of the systemic condition is enough to control the retinopathy. In presence of diabetic macular edema, patients are classified either into non-centrally involving or centrally involving diabetic macular edema. For those patients with non-centrally involving macular edema, the preferred line of treatment is laser treatment. However, anti-VEGF may be used. In case of centrally involving diabetic macular edema, the first line of treatment is intravitreal injection of anti-VEGF. If the patient responds well to the treatment, then continue on the anti-VEGF. If there is no response, shift to another anti-VEGF. If no response for the second anti-VEGF drug, then shift to corticosteroids. Anti-VEGF leads to regression of new vessels. It can be used in treatment of proliferative diabetic retinopathy. However, the treatment is costly because it may be used for life. This slide shows an example of macular edema that is sparing the center of the fovea. This edema can be treated either by anti-VEGF or by focal laser treatment. In order to judge if the edema involving the center or not, do not depend upon fluorescein angiography. If you look at this angiogram, you may suspect that this patient has a centrally involving macular edema. However, this is the OCT of this patient. And as you can see, the edema is not involving the center. So, centrally involving macular edema is best detected by OCT. On the other hand, if you look to the angiogram of this patient, you see widened, irregular foveal avascular zone. This indicates some sort of ischemia. However, this is not contraindication for the injection of anti-VEGF. The edema seems to be away from the center of the macula. This is the OCT. There is a central macular cyst. This is an indication for anti-VEGF. The FDA approved dose for Lucentis is 0.3 milligram. Note that it is slightly lower than that for CNV or macular edema for treatment of vein occlusion, as we are going to see later. The dose of Avastin is 1.25 milligram. Note that it is not FDA approved. And the dose of Eylea is 2 milligram per month. And the loading dose for Eylea is supposed to be for 5 months. That for Lucentis and Avastin are for 3 to 6 months. The expanding indication of anti-VEGF include proliferative diabetic retinopathy. Anti-VEGF leads to regression of the new vessels. However, the great disadvantage that limits the use of anti-VEGF in treatment of PGR is its cost. Because in order to control the PGR, patients should take the treatment monthly. Treatment can be used in patients with media opacity or after failure of control of the PGR by panretinal photocoagulation or pre-vitrectomy to decrease the vitreous hemorrhage and improve the prognosis after vitrectomy. The leading cause of vision loss in retinal vein occlusion is macular edema. Branch retinal vein occlusion is more common than central retinal vein occlusion. Before the introduction of anti-VEGF, there was no definite treatment for macular edema secondary to central retinal vein occlusion. Laser treatment would improve the macular edema in central retinal vein occlusion angiographically, but will not improve the vision. Thus, intravitreal injection has introduced a treatment for those patients. The dose of Lucens is 0.5 milligram. The dose of the Avastin is 1.25 milligram. And the dose of Eylea is 2 milligram per month. Treatment should start as early as the development of macular edema. Myopic choroidal neovascularization is another indication for intravitreal antivascular intracellular growth factor. The treatment protocol is either 1 plus PRN or 3 plus PRN. PRN means as needed, meaning that whenever the patient needs the treatment, based on visual acuity and OCT findings. However, studies have shown that the results are superior in using 3 plus PRN, meaning 3 doses, then followed by injection whenever there is deterioration in the visual acuity or in the OCT thickness. Retinopathy of prematurity is a significant cause of childhood blindness worldwide. The introduction of intravitreal anti-VEGF injection in those babies have introduced a new hope. Indication is stage 3 plus, zone 1 or posterior zone 2. However, 3 points has to be considered in those babies. First, the dose is half or sometimes in some studies a quarter of the adult dose. second point is that those babies are still developing. They are in need of vascular endothelial growth factor. And the systemic absorption of the drug and its effect on the developing baby is not yet known. Those children should be monitored very well. The third point is that the anatomy of those babies are different from the anatomy of the adult eye. This slide shows the site of injection according to the age of the patient. To date, there is no single effective treatment for neovascular glaucoma. Intravitreal injection of anti-VEGF can be used in neovascular glaucoma in cases of media opacity, preventing efficient laser treatment. It may be used in severe cases of neovascular glaucoma as an adjuvant treatment. Or in those patients who cannot undergo laser treatment. Now, we are going to discuss intravitreal injection of steroid. First, intravitreal injection of triamcinolone acetonide. The dose is 4 milligrams. However, some researchers have used a dose high as 20 milligrams, and others have used a dose of 2 milligrams to decrease the side effect of the steroids. It's indicated in cases of non-infectious posterior uveitis, resistant macular edema in diabetes mellitus or retinal vein occlusion, and in resistant Irvine-Guest syndrome, which is macular edema following cataract surgery. Another injectable steroid is dexamethasone. It is injected in the form of dexamethasone implant. The trade name is Ozurdex. The dose is 0.7 milligram. It is indicated in cases of diabetic macular edema in pseudophakic patient or in phakic patient scheduled for cataract surgery. In macular edema, in retinal vein occlusion, in non-infectious posterior uveitis, and in resistant Irvine-Guest syndrome. What are the complications of intravitreal injection? Complications are either related to the injection procedure itself or related to the injected drug. The injection may produce mild pain at the site of injection, or hemorrhage at the site of the injection, or in a small percentage of the patient, vitreous hemorrhage can occur. reflux of the injected drug can occur. Intravitreal injection leads to transient elevation of the intraocular pressure. Studies have shown that the use of alpha-GAN 20 minutes prior to anti-VEGF injection can decrease this transient elevation of the IOP. In very rare cases, injection can lead to retinal detachment or endophthalmitis. Post-injection endophthalmitis is a nightmare of retina specialists. Incidence of endophthalmitis following intravitreal injection of triamcinolone acetonide is about 0.6%. In cases of intravitreal injection of anti-VEGF, the incidence varies from 0.9% to 1.6%. The injectable drug can lead to intraocular inflammation or drug-induced uveitis. Using a special algorithm designed for assessment of drug-induced uveitis, it was suggested that anti-VEGF agents are definite causes of drug-induced uveitis, while triamcinolone acetonide are probable cause of drug-induced uveitis following intravitreal injection. The incidence of intraocular inflammation following intravitreal injection of anti-VEGF ranges from 1.4 to 2.9%. However, every effort should be done to exclude infective endophthalmitis before diagnosing drug-induced uveitis. Some complications are related to the drug itself. In cases of intravitreal injection of anti-VEGF, there is a potential risk of arterial thromboembolic phenomena. So it's contraindicated to inject anti-VEGF in patients with recent history of stroke. Systemic absorption of anti-VEGF may lead to non-fatal myocardial infarction or stroke. Central retinal artery occlusion have been recorded in some patients following intravitreal injection of anti-VEGF. Intravitreal injection of steroids may lead to glaucoma plus or minus cataract. There is a rise of intraocular pressure in 25 to 50% of patients receiving intravitreal injection of triamcinolone acetonide. 1 to 2% of those patients will need glaucoma surgery. The incidence of glaucoma increases with repeated injection. 50 to 90% of patients receiving intravitreal injection of triamcinolone acetonide will have posterior subcapsular cataract within 2 years. 15 to 20% of them will need surgery within 1 year, as the cataract is visually handicapping them. Thank you.